And there we go. So good morning again, everyone. My name is Mark Driscoll. I am the program manager for the Preventive Health Program with the Ohio AAP. We have with us today also our medical director, Dr. Chris Bowling. Just a couple short notes from me. For everyone that is attending, I will send out information either the end of today or tomorrow about obtaining your CME credit. So I will send that out in an email tomorrow for instructions on that. And then we do want to make sure to thank our partners, the Ohio Department of Health, for helping us with this presentation and to get this off the ground today. And then without further ado, I'm going to go ahead and kick it over to our team to introduce themselves and begin the presentation.
Thank you, Mark, and thank you to all of us joining us today or eventually listening to this recorded webinar. It is very cold live in Ohio, so hopefully everybody is staying warm and that your patients are still showing up to clinic. So we are going to talk today about CF newborn screening in Ohio and really target our talk towards what the primary care provider should know. Let me make sure. Yep. Okay. A disclaimer first. So the views and opinions expressed are ours. They don't represent the Ohio AAP or the Ohio Department of Health. And we have no relevant financial relationships or anything to disclose. So we are coming to you from 3 different hospital systems across the state, and I'll allow each of us to introduce ourselves.
Good afternoon. I'm Dr. Silvia Cardenas. I'm a pediatric pulmonologist in Cleveland Clinic Children's. And I am the director of the newborn screening program in our center and the associate director of the CF Center here.
My name is Jessie Roach. I am a nurse practitioner and I am the CF Center coordinator at Cincinnati Children's Hospital.
I'm Julianne Hartman. I'm a genetic counselor at Cincinnati Children's Hospital, and I coordinate follow-up for babies who have abnormal newborn screens for CF. And I also provide genetic counseling services to those families when they come in for follow-up testing. And I do that both at Cincinnati Children's and via telehealth with ProMedica in Toledo.
And I'm Caitlin Krivchenya. I'm the director of our CF newborn screening and infant newborn clinic at Nationwide Children's Hospital in Columbus. So we do have, I guess, some funding to disclose. The Cystic Fibrosis Foundation is supporting a grant to help us form an Ohio newborn screen collaborative, where we're working together with the 7 centers in Ohio to try to improve the process of CF newborn screening and really try to decrease the late or misdiagnoses of cystic fibrosis in Ohio. Part of that is some educational outreach to primary care providers. And so we're lucky to be able to partner with the Ohio AAP to help with this webinar. So we're going to try to hit on 3 major topics today. The first, we're going to explore changes in the prognosis for babies with CF with the advent of new therapies and with early treatment. It's very likely that lots of things have changed since you went through your medical training. So we're going to provide an update on that. We're going to try to understand the limitations of the Ohio newborn screen for CF because we are still missing babies in our state, and talk a little bit more about what the next steps are when you have the abnormal newborn screening for CF, and then also give a little bit of a preview into the changes that are coming our way.
So before we can get into all those details of those objectives, we need to give a little background about cystic fibrosis, and I will kind of start by doing that on the genetic and molecular level here. So like most of the conditions that are on our newborn screen, CF is also inherited in an autosomal recessive manner, and that's kind of the point of newborn screening. We want to identify babies that wouldn't otherwise be picked up because of a known family history or a parent that's affected. These are recessive conditions, and a lot of parents don't know that they're carriers for these conditions. So we kind of think, with the image that is on the left-hand side of our kind of traditional carrier model, like basically this or Punnett squares, I think is what we often think of, where you have 2 carrier parents who are unaffected and, like I said, may not know they're carriers, with a 25% chance with each pregnancy they have to have a baby who's affected with cystic fibrosis in this case. What I will say that's kind of been nice as of late, for about the past 20 years, ACOG has been recommending offering carrier testing to any couples preconceptually or prenatally for cystic fibrosis specifically. And now that we have next generation sequencing and the cost of these tests is coming down, it seems to be more accessible to a lot of couples, because as I'm calling out these newborn screening results and talking to families about them, I'm finding more and more families seem to already know this information if they're carriers or if they're not. So for families who are getting information from the newborn screen where the baby has 2 variants and we're pretty sure that they have cystic fibrosis, they might already know that that was a risk for them, which is kind of nice to have sometimes. Or I might be talking to the family of a baby with only 1 variant identified, where maybe mom is a carrier, but dad had negative carrier testing. And of course, in those cases, because as we're going to talk more about, there's some limitations to genetic testing in general, as well as, newborn screening and carrier screening, we still think it's very important to get follow-up testing done, but can still be reassuring with those families that most likely we're dealing with a situation where baby is just a carrier. So not everyone has that information, but I'm finding more families that do get genetic testing done. And the other thing I want to point out on this slide is kind of a situation that we wouldn't really have been in a lot 20 to 30 years ago, where you see an individual who has cystic fibrosis actually having their own children. And as many of you probably know, women who have CF, they can have reduced fertility, and that can depend on a lot of things like nutritional status and whatnot. But many women who have CF can achieve a pregnancy, and with earlier diagnosis and with a lot of the new treatments that are becoming available, quality of life is increasing, life expectancy is increasing, and more people who are adults with CF are having their own families. So I might be seeing them in my genetic counseling clinic to help coordinate carrier testing for their partners, or if we already know that their partner is a carrier, I might be counseling them on what a certain combination of variants might look like in their baby, because at that point, someone with CF and someone who has a partner who's a carrier would kind of be at a 50-50 chance whether that baby is just a carrier or would have cystic fibrosis. But it's still very exciting that we get to see families in this situation now. And so then moving on a little bit more to the molecular side of why cystic fibrosis causes these problems. There are as you probably already know, the gene that causes cystic fibrosis when it's not working correctly, it codes for a chloride channel. And this is an absolutely huge gene, and it creates this really big, complicated channel that has a lot of different functional domains. And we have found about 2,000 different variants that can alter the function of the CFTR protein. So some variants are going to make it so that no protein is made at all. Other variants are going to make a pretty normal protein, but maybe the variant is in a place that doesn't allow the signal to get it to the cell surface where it's supposed to be functioning. Some other variants, like splice site variants, can make some abnormal mRNA that gets degraded, but some of the mRNA will be normal. So some normal protein eventually gets made, but it might be a much less amount than would be optimal in the body. And then lastly, some CFTR variants can change the function when it actually gets to the cell surface. So the right amount of protein is made, it gets where it's supposed to go, but maybe the variant is causing a change in like a binding site that's supposed to regulate how that channel opens. So there's a lot of different things that our therapies these days can target, which Sylvia will talk about in a little bit. So it's kind of an exciting time to be working in CF because we have all these therapies available, but this is kind of where we are from the molecular standpoint, and I'll turn it over to Sylvia now to kind of talk about what these symptoms look like in patients.
So now that we have seen what happens at the molecular level, we can see what happened at the clinical level. Most people, when we think about cystic fibrosis, we think about lung disease. And indeed, cystic fibrosis is a disease of the lungs because the lungs are universally affected in all patients with cystic fibrosis. And not only that, but lung disease and respiratory failure are still the leading cause of death in our patients with CF. However, cystic fibrosis is a multisystemic disease. Essentially, anywhere in our body where we have tubes, we can have these inspissated mucus or secretions blocking these tubes and causing problems. Besides the lungs and the sinuses, another organ that is largely affected is the gastrointestinal tract, including the pancreas, the liver, and the bowel. Most of our patients with CF have pancreatic insufficiency, and that means that they are not able to absorb fats, and this will lead to malnutrition. And we need to treat this very early on with a lifetime administration of pancreatic enzymes. The liver is also affected. And as I mentioned, the problem with the tubes and the inspissated mucus, actually the liver cells are not affected in CF, but what it is affected is the intrahepatic biliary system that gets clogged with secretions and will cause cholestasis, leading to liver disease and ultimately cirrhosis. And another problem in the GI tract, besides the malabsorption and the malnutrition, is that patients could present with constipation and intestinal obstructions. And actually, I want to highlight here the fact that meconium ileus is also part of this spectrum of the bowel affected by CF. And one important thing to highlight here is that to remember that patients or babies with CF presenting with meconium ileus tend to have lower levels of IRT, which we're going to talk about later with the newborn screening. So I want to remind you that whenever we see meconium ileus as the cause of the intestinal obstruction in neonates, we have to think about cystic fibrosis regardless of the result of the newborn screening. Julian has talked beautiful about the reproductive system and how it is affected by CF. And finally, I want to mention the sweat glands as well. The sweat glands are affected in CF. The epithelial cells there are also having an abnormal salt and water exchange. And this will lead to an excessive salt loss with higher levels of chloride in the sweat, which is what we are able to use for the diagnosis. Now, the management of CF has traditionally relied on treating the complications of the disease and trying to break this cycle of infection and inflammation. This is a vicious cycle that happens in the lungs of people with cystic fibrosis. We start here at the top of the slide with the abnormal electrolyte and water exchange in the epithelial cells, leading to this inspissated thick mucus that will plug the airways and cause airway obstruction. This will predispose the airways to become chronically infected with bacteria and cause further more inflammation, more mucus production, to increase the mucus plugging the airway obstruction that ultimately will lead to structural lung damage and bronchiectasis. And once patients develop bronchiectasis, which is pretty much universal in the lungs of patients with cystic fibrosis, the airway clearance will become even more compromised. The secretions will be more difficult to move, and this will further impair the airway clearance to continue this vicious cycle. So our interventions to this day have included to use medications that will help us to thin out the mucus, such as bronchodilators or hypertonic saline or Dornase alpha that we know as pulmozyme, or using devices such as the chest oscillator or a cappella devices, or countless hours of manual percussion that our patients with CF need to receive. We have also used antibiotics, mostly in the inhaled forms on chronic basis to treat the chronic bacterial infections that our patients have. But also we will use IV antibiotics intermittently when our patients will present with pulmonary exacerbations. And these pulmonary exacerbations are acute changes in the status of our patients that happen intermittently, and our patients with these exacerbations will need to be admitted to be treated with intravenous antibiotics. Another medication that we have used is anti-inflammatory therapy, and probably you have seen macrolides using on a long-term basis in our patients, and this is mostly for the anti-inflammatory effect. So all these interventions that we have continued in CF have had the goals to preserve the lung function in our patients and also to reduce pulmonary exacerbations. How do we measure lung function in our patients? So to this day, the best way to measure lung function is measuring forced expiratory volume in the first second in spirometry. Perhaps not the greatest indicator, but today this is the best indicator that we have, and the FEV1 remains the best predictor of mortality, because we know that the lower the FEV1 in our patients, the higher risk of mortality, morbidity, and mortality that they will have. We also try to reduce pulmonary exacerbations. And why is this? Because we know that our patients, even with the best care, they will lose lung function about 1 or 2% per year of their lung function. And many times with pulmonary exacerbations, the FEV1 will drop to significant levels that many times they are not able to recover even after treating optimally the pulmonary exacerbation. So we are trying to prevent these occurrences of flares in their lung disease, to prevent development of structural lung damage and end-stage lung disease. Another big goal in CF care has been nutritional status, improving nutritional status, because we know that BMI is very much correlated with improved outcomes. Patients with improved BMIs have improved outcomes, improved lung function, and the opposite occurs, that when the BMI is low, these patients will have a reduced pulmonary function, more morbidity, and mortality. And this is even true in patients after transplant. So in patients that receive organ transplant, lung transplant from their CF, if we don't keep an eye on the weight trajectory or in the BMI trajectory, then we are setting up for the poorest outcomes. I want to show you in this timeline the history of cystic fibrosis. And you can see throughout this how many therapies have been implemented throughout the years for the care of cystic fibrosis. And not only we have used medication that have essentially specifically created to treat the complications of the disease, but we have also standardized the care of patients with CF through the Cystic Fibrosis Foundation and also the Care Center Network. The Care Center Network is a nationwide network of professionals with expertise in cystic fibrosis, and also partnering with patients that have the disease to provide the best care possible for the patients. Today, there are approximately 130 or more of these care center networks, and in Ohio, we are lucky to have 7 of these. These 130 are nationwide, and in Ohio, we have 7 of these. Another thing that I want to highlight in this timeline is particular 2 big milestones in CF care. One of them is the newborn screening, which we're going to talk about it for the rest of the session as well. But I think one of the most important things with the newborn screening was the implementation of the newborn screening as a nationwide program in 2010. Ohio had been performing newborn screening since August 2006, but this became a nationwide program in 2010. And with this program, we have been able to achieve diagnosis in babies with CF as early as 2 weeks of age. And this has improved the possibility to provide early intervention and early treatment, especially in patients, for example, that are pancreatic insufficient. We can start treatment early on with pancreatic enzymes, and this changes the weight trajectory and the nutritional outcomes. And not only that, but also patients that when they are meeting their providers in the CF center at an early age, they are, this is a critical step to establish that relationship that they will have for the rest of their life with their CF centers. And another big milestone in the history of CF, and that I want to show you in this timeline, is the discovery of the CFTR modulators. The CFTR modulators, as Julian mentioned before, are drugs that were specifically used to treat the underlying defect in the CFTR protein and are able to correct partially that abnormal salt exchange. So we started in 2012 with the discovery of ivacaftor or Kaleidoco, and this medication was used only for certain specific mutations in the CFTR gene. And these follow with Symdeko and Orkambi, which are a combination of drugs. But even to that day, when we have Symdeko or Orkambi, we did not have a medication that was able to be used in the majority of the CF population. So definitely that was the goal. And finally, that happened with the discovery of Trikafta or elexacaftor, tezacaftor, ivacaftor. It's a triple drug combination medication that is used in patients that have at least one copy of A508 deletion. And as this is the most common mutation, this medication has been able to be used in patients that have at least one copy of that, and this has encompassed 90% of the CF population. So definitely this was a big step, a breakthrough in therapy, because for the first time in the history of cystic fibrosis, we have had a medication that is able to treat the underlying defect of the disease rather than the complications as we have been traditionally doing. Now, there is a modulator for everyone, not yet. Not everybody is eligible for a modulator, but progress continues to be made. And as we were getting ready for this talk, one other CFTR modulator was approved by the FDA exactly a month ago today. And this is Aleptrek, which is another triple drug combination therapy that can be used in patients that are eligible for Trikafta, but is also including 31 other rare mutations that previously did not have therapy. So definitely progress continues to be made, and it will continue to be made until we have a modulator for everyone. Now, by now, you have seen how the CF landscape has changed dramatically. Cystic fibrosis is not the diagnosis that we had 20 years ago. We have the possibility now of early diagnosis, early therapy, and that has changed significantly the outcomes. And with that has come an improvement in the median predicted survival of patients. This graph has information from the last CF Foundation registry in 2023. That is showing the median predicted survival in patients and how this has improved since the early 90s, when the survival was predicted 25 years of age, and it has increased to 61 today. So what this means is that half of the population that is born with CF today, or between 2019 and 2023, as the intervals in this graph, is expected to live past 61 years of age. And this age will continue to improve since, we are not including data, or we are not completely accounting for the use of the modulator that is happening just in recent years. So, my hope is that today you can take home the message that CF outcomes have dramatically improved over the past years. And the conversations that we have with our patients today are not the same that we had 20 years ago. We can finally offer hope to our families that early diagnosis will improve the outcomes when we are meeting them. But these outcomes will only improve if we treat them early, the patients early. And for that, we also have to diagnose them early. And with that, I'm going to pass the baton to Kaylin to talk about the diagnosis.
So there are times when CF can be actually a challenging diagnosis to make. It's a multiple step process. It requires a comprehensive evaluation. If you only look at one piece of the puzzle, you can miss the bigger picture. So the newborn screening has been a phenomenal tool to help us identify babies with CF, but it's not enough in and of itself to make the diagnosis. And that's why this puzzle piece is slightly removed, because it's a screening test. It's a valuable tool, but it won't catch all of our cases. So we have to put all the pieces together to help solve the puzzle. In order to make a diagnosis, we need a combination of diagnostic tests like sweat testing and genetics, plus a clinical evaluation. So when you consider the technical diagnosis, the technical diagnostic criteria for CF, there are really two categories. So something that keys you in to that CF might be a possibility clinically, and evidence of CFTR dysfunction. So the things that can key you in to possible clinical involvement are certainly showing symptoms, which Sylvia outlined quite nicely, like the different symptoms we can have, having a positive newborn screen, or having a sibling with cystic fibrosis. And then we can show evidence of CFTR dysfunction by having positive sweat tests, that's a sweat test over 60, or a mutation analysis where we see 2 disease-causing mutations. But it doesn't always fit in this nice box. So maybe a sweat is borderline. And what does that mean? It's not quite normal, but it's not too abnormal. Maybe only one mutation is identified. Maybe you're not quite sure if the symptoms are actually due to CF or something else. So we have to take several things into account.
So now that we've heard more about the CF disease, let's dive in a little further with the newborn screen. So as Caitlin said, the newborn screen is just that, it's a screening. It's not perfect and there will be missed cases. The newborn screen is a tool that can be used to help guide further evaluation and care. So as Sylvia stated, so newborn screen started nationwide in 2010, and we actually started in Ohio in 2006. Unfortunately, newborn screens can vary by state, and some are more thorough than others, which can be complicating. All states start by screening the immunoreactive trypsinogen, or IRT level. So in infants with cystic fibrosis and pancreatic dysfunction, a pancreatic enzyme release is impaired, and the IRT is not readily removed from the bloodstream, which causes an elevated IRT blood level. In Ohio, we use a floating cutoff, which means that the top 4% of IRTs resulted each day are sent for further testing. What this means is that 2 babies who are born on different days can have the same IRT level, but only one gets sent for further testing due to a lower average IRT level that day. So clearly, this can lead to missed cases. If the IRT is elevated, that same blood spot used for IRT testing is sent for DNA analysis for 39 of the most common CF mutations. If one genetic mutation is identified, a sweat chloride test is needed to differentiate a CF carrier versus a person with CF disease. And then if two genetic mutations are identified, we presume that that baby has cystic fibrosis, and clinical evaluation and treatment should be started right away. So we know that the IRT is not a perfect measure and can sometimes be unreliable. There are certain scenarios that can cause an IRT level to be falsely high or falsely low, which further complicates CF newborn screening. Things like prematurity or hypoglycemia can cause a falsely elevated IRT, and things like meconium ileus or bowel atresia can cause falsely low IRT levels. If an IRT is falsely low, the newborn screen is then reported as normal, which is concerning because it could provide false reassurance to the primary care provider that CF is not a concern in that baby. It is important for the PCP to be aware of conditions that can cause a falsely low IRT level so that they know the newborn screen is less reliable, and they should use other evaluation tools to determine if further workup for CF is necessary. In general, we would err on the side of caution and recommend further testing or further evaluation with a sweat test if there's any suspicion for CF. And even babies who have a condition that we know causes a falsely elevated IRT level, such as prematurity, should still get the recommended follow-up testing, which would be a sweat test. So this is what our newborn screens currently look like. We'll run through some scenarios later on, but just wanted to orient you to interpreting these results because it's a lot of information. So the first row highlighted in green shows 5 columns on the screen, starting with the test performed, the value of the patient's result, the normal reference range of the test, the risk level, and the action. The second row highlighted in red is the CF screen. The test column is labeled IRT. The value is the patient's IRT level. In this example, it's 162.9 nanograms per milliliter. The reference range is below the 96th percentile that day, meaning not the top 4% we talked about earlier. The risk level is elevated on this screen, and the action is listed as 1, which guides you to the associated recommended actions. Because this IRT is elevated, there's an additional row under the IRT test that's labeled CFTR mutations, and in the value column is the mutation found for this patient on that 39 mutation panel that we use in Ohio. This example shows 1 mutation. There could be 2 mutations listed or the words 0 mutations, meaning that the patient does not have any of those 39 mutations we screened for in Ohio. At the bottom in yellow You have your recommended actions, which provide guidance for next steps for the PCP. In addition to this screen, PCPs will also get more detailed guidance for next steps, as well as contact info for the Ohio CF centers. So genetic testing can be done in various ways for CF. The common mutation panel looks at a smaller number of known disease-causing variants, and different labs do test for different number of mutations. In Ohio, if the IRT is in that top 4%, a common mutation panel is performed using that same blood spot to screen for 39 CF causing variants. This method does allow for quick results, but the mutations screened for in that panel are mutations most common in white individuals. So non-white babies are likely to be missed with newborn screening and are often overlooked as a possible diagnosis because CF is still sometimes thought of as a white disease, which is clearly not true. A more thorough testing option is CFTR sequencing with deletion and duplication analysis, which looks through that entire CFTR gene for all possible CFTR mutations. It is not part of the newborn screen process. It has to be ordered and obtained separately, so it doesn't use that same blood spot we could collect for the newborn screen. It can take weeks to months for results, and the results can be confusing because we don't know how every mutation affects people clinically. Mutations are classified as either CF causing, non-CF causing, or variants of varying clinical consequence. So digging into sweat testing. So the sweat chloride test remains the gold standard for CF diagnosis. Newborn screen is helpful in identifying those who need more testing, but is not diagnostic and is only as good as the follow-up that it prompts. Sweat testing measures the amount of chloride in the sweat and provides an objective measure of how CFTR protein is functioning, and it is the most reliable test to diagnose CF. Educating the family of what to expect at the sweat test is important. Basic guidance for parents could include things like the test is painless, it may cause a tingling sensation, takes about an hour to complete, results are typically available the same day, and it's important to dress warm to help get as much sweat as we can. And then sweat chloride results. So the timing of the sweat test is tricky and will likely vary between each CF center. We do want to get the baby in and get results so that we can start treatment early if the baby does have CF, but we also don't want to risk not getting enough sweat and causing more stress for families and the need for repeat testing. For one mutation babies, a sweat test is usually recommended 3 to 4 weeks after birth or 3 to 4 weeks adjusted age, ideally when the baby is close to 8 pounds. We collect sweat on both arms or less preferably on both legs and measure the amount of chloride in that sweat. There are 4 different possible results of the sweat test. So less than 29 millimoles per liter is considered normal, meaning that CF is unlikely. A result of 30 to 59 is considered intermediate, meaning that CF additional workup is needed, which is often evaluation by a CF provider and a repeat sweat test in a month or so. A result of 60 or more is considered abnormal or positive and is diagnostic for cystic fibrosis. And then QNS, or quantity not sufficient, means that we didn't collect enough sweat to perform the test and the test will need to be repeated. For one mutation babies with clinical concerns such as poor weight gain or greasy, foul-smelling stools, we may opt to perform the sweat test earlier than 3 to 4 weeks. We will always err on the side of caution. Even if the level is 29 on one arm and 30 on the others, we'll recommend additional testing. If the results vary from one limb to the next by 10 millimoles per liter or greater, we worry that it was a bad test and we'll recommend repeat testing as well. For babies with elevated IRTs and 0 mutations, a repeat newborn screen is recommended at 4 weeks of age. And if the IRT is still elevated, a sweat test is recommended to rule out cystic fibrosis.
So the general timeline for testing, again, will vary. And this is just to kind of give you a visual for what Jesse just went through, but that heel stick happens between 24 and 72 hours of age. And then usually by that 1 week, maybe 6 to 9 to 10 days, PCPs and CF centers should be getting notified by the ODH about the abnormal newborn screen. And the center that's responsible for the screening region and the PCP will be notified. And And then to reflect what Jesse said, babies with 2 variants are seen as soon as we can to start treatment. And babies with 1 variant generally are sweated within 4 weeks to complete that evaluation. So we wanted to take the next couple minutes to talk about some late diagnosis cases that actually have been, they've each occurred in Ohio at our various centers over the past few years, just to highlight the fact that this is absolutely happening, that we're missing babies. So this one was from my institution, a patient that had this newborn screen. You can see that the IRT level was elevated at 126.9. And you can tell that the newborn screen was flagged because it says 0 mutations. So we know that the IRT was high that day. They ran mutations and it was 0 mutations. And so the risk level is low. So when you're looking at the screen and you're just looking at this results in your office and you're just looking for it, you could say, oh, it's normal. But it's not normal, particularly if you know a little bit about the history of this baby. So this baby ended up having parents that were both CF carriers. There was known echogenic bowel on ultrasound during the pregnancy, and the baby was of Hispanic ethnicity. So each of those things should cue you in that this newborn screen should not be the end-all be-all in terms of us thinking about CF. And unfortunately, this baby was diagnosed at 3 years of age during a hospitalization for severe respiratory failure. Her sweats were over 100. She had 2 rare mutations that would not have been caught on the general ODH screening panel. And unfortunately, this patient had lots of follow-up with primary care, also was referred to specialists, so had lots of physicians and care providers that had the opportunity to potentially intervene and recognize this before she had terrible bronchiectasis and lung disease.
This is another case that we have with late diagnosis that is actually a patient that was seen in our hospital. It's a child who is at 21 months old when he presented to the hospital, Caucasian and coming from an Amish family. The past medical history was not significant other than he was a home birth. And when we inquire about newborn screening, the parents reported that this had been negative. And it was performed by the midwife that attended the delivery. The patient presented with classic symptoms of CF when we saw him: weight loss, abdominal distension, pale stools, steatorrhea, chronic cough, and on physical exam, he was at that point having an acute pulmonary exacerbation with some mild tachypnea. And we also noticed that his nutritional metrics were very below optimal. His weight was in the 3rd percentile and his length in the 6th percentile. And his weight for length at that time had a C score of -1.5, which put him on the category of mild to moderate malnutrition. So this baby had sweat chloride testing and it was 98 and 101, which is very diagnostic of cystic fibrosis. His stool elastase also was very low, revealing severe pancreatic insufficiency. And we performed genetic testing, and he ended being a homozygous F508 deletion. So these two are this is the most common mutation, and this patient was homozygous for that. So with this information, we inquired the family about the newborn screening, and it turns this patient was born in Pennsylvania, has seen several doctors because he has been getting ill frequently in the past few months. And the newborn screening had been actually performed by the midwife, but it wasn't the Department of Health screening. It was a screening that they had done just for metabolic diseases, and it did not include cystic fibrosis. Now, you can see here in these graphs how after the initial encounter with this patient, the first hospitalization that he had, and the only hospitalization that he ended up having, his weight significantly increased with nutritional management and administration of pancreatic enzymes. He also was starting on a regimen of airway clearance. The family has been very adherent to therapy, and this kid now is 5 years old, has a normal lung function, and you can see also his BMI is at goal. It was a goal at the moment of this graph, but now he remains at BMI goal above 50% and has an FA1 that is 100%.
So another case from my area was a patient that had a very normal newborn screen. So there's nothing to argue about this one. The IRT was 59.3. It was the within that 96th percentile. Risk level was low. But this baby had several months of kind of a mucousy cough that never really cleared. It was also during viral season. So how much of this is just viruses? He was gaining weight, but he was needing to eat 60 ounces a day in order to gain that weight. He had lots of loose stools. They fortified his feeds. They treated him for reflux. He was just hungry all the time. And luckily, his mom was in the medical field and had a concern, and so advocated for a sweat test. And baby ended up with sweats over 80. So this is a case of newborn screen, just simply that IRT not being big enough to flag that day. And so we missed this diagnosis until he was about 6 months of age. And then you can see when he started enzymes, so he was holding his own on the curve with those 60 ounces a day. But once he started enzymes, he was able to go down to eating a normal amount of food for an infant, and still maintain robust growth.
And the last case is from the Cincinnati area. And this is kind of a different case because the newborn screen actually did flag. So this baby I probably met about 7 years ago now. And I met with them when they were coming in for the sweat chloride testing. And I'm not going to lie, this newborn screen did not make me concerned. This looked like a classic newborn screen for a baby that's a carrier. Generally, that top 4% cutoff is usually somewhere in the 50s and 60s, not always, but generally somewhere around there. So when I see an IRT level, it's kind of just skates in above that cutoff, and this being 72, kind of fit that criteria. So this baby, because it did flag though the IRT, they did have genetic testing done and had one variant identified. So it wasn't until I met with the parents who then told me they are both CF carriers that I kind of went, okay, well, maybe we need to figure out if this is something we need to investigate a little further. But the baby's sweat chloride test that day happened to come back normal, completely normal range, 23 on both arms with 29 and under being normal. So at that point, and mom had already voiced some concern about not being able to get her carrier test results because the OB that had done that testing wasn't in practice anymore. So I told the family, if you can get your results, great, but if not, has a normal sweat chloride test, we can resolve him as a carrier to ODH. But of course, that's not what happened with this baby. So he kind of, in retrospect, has this sort of chronic cough, and he ends up in urgent care, periodically for upper respiratory infections. But it wasn't until he was about 3.5 and had some pretty significant abdominal pain that got him admitted to the hospital. And at this point, his care team reached out to the CF center to ask if there was still a chance that this could be cystic fibrosis related, because they saw that he had had that abnormal newborn screen. So the first thing I recommended was that parents, locate their carrier test results just to kind of see what variants we're dealing with. Because when we have pancreatitis, I will say there are some other genes that can cause that in conjunction with a CFTR variant. So like SPINK1, for example, is another gene that you can have a variant in that gene and a variant in CFTR. So I thought, well, maybe it's something like that. But that was not the case. So parents were able to dig up their results. Dad had the same variant that the child had on his newborn screen, but mom had this really mild variant, D1152H. And that is not a variant, of course, that is on that 39 variant panel that Ohio does as part of the newborn screen. So that wasn't detected. And of course, what we know about this combination of variants is not everyone who has even the F508del and D1152H is going to meet criteria for cystic fibrosis. The D1152H has, we call it variable consequences, where some people might meet criteria for CF, but then others won't. And the ones who don't usually have are pancreatic sufficient. So they usually don't have that failure to thrive kind of presentation, like this kiddo did not. So it was kind of this red herring that, the sweat chloride was normal, that I think some of his symptoms kind of went, undetected, or we didn't really think about cystic fibrosis until the pancreatitis came up. So at that point, they repeated the sweat chloride testing, and it is now borderline. So with symptoms in the lungs and in the pancreas and a borderline sweat and an abnormal newborn screen, he actually now meets criteria for cystic fibrosis, and he had his first visit with the CF center right before he turned 4. So a lot later than he probably could have, but that normal sweat test kind of threw us off.
So I think you've heard all of us say at this point, if you take nothing else away from this presentation, that the newborn screen for CF is not perfect. It is just a screening test. And that if there's ever any concern for cystic fibrosis, get a sweat test. So no matter their age, ethnicity, or if their newborn screen was normal, a sweat test is never the wrong answer.
So now we've spent all this time talking about how this process works now. So there are some changes coming our way in Ohio. In the summer of 2024, Governor DeWine announced that they were going to be expanding the breadth of newborn screening for CF in Ohio, trying to make sure that we're being more equitable and we don't have any missed babies is the goal. So that's easy for somebody to say, but to actually roll it out and make this process happen has been quite a feat. And kudos to our ODH friends who are on the call for all the work that's been going into this. But that's one of the reasons that we as centers in Ohio have gotten together to try to make sure that as we roll out these changes that they make sense and then they're appropriately communicated to providers across the state. So this is just a schematic that shows exactly what we've talked about so far. Right now, we have an IRT DNA process, but we're going to move to an IRT DNA sequencing process. So let me talk to you about what that is. We're still going to measure IRT the way we did before. So all those places where IRT failed us, those are still going to be potential places where the newborn screen fails us. We are going to still use this floating cutoff. We are going to add a lower limit cutoff so that any baby who is over a number of, like, let's say 65 or 60 will also get the DNA testing done. But if that IRT is elevated, then we're actually partnering with University of Wisconsin lab to do an expanded genetic analysis, an actual DNA sequencing of that CFTR gene. So initially that blood's going to be analyzed for over 600 CFTR variants. So our quality here in genetic detection is going to go way up. And certainly if 2 variants are found, we're going to have our diagnosis potentially faster for some of these patients than we'd had in the past. And if 0 variants after this breadth of screening for genetics, we're going to feel really comfortable that those babies are very, very low risk. If we have 1 variant, we're still going to sweat. So the process of getting a baby in with a 1 mutation identified for sweat testing is still going to be there. And if that sweat testing is abnormal, we can go back to that lab and they can unveil the full sequencing of that CFTR gene without having to draw more blood or wait a prolonged period of time for testing results. So we're excited about what this relationship is going to be. We're still going to sweat the kids with 2 mutations. Those kids are going to be coming in and getting clinical care. So we'll still confirm their diagnosis. This go live is about any time now. So Q1 of 2025 is what we're hoping for, where all this is going to happen. So what's that going to mean for you guys? So again, that's why we're working together. I wanted to show this map. This is the screening regions for each of the hospitals who have newborn screening centers. So for instance, if you practice in screening region 3 up there in the top left, that is Toledo Children's region. You probably already know what your hospital is, but you can tell some of these regions are bigger than others. Some hospitals like Cincinnati actually covers other states as well. Some hospitals like their Cleveland hospitals share the same region. So it's as everything, it's a little bit more complex the more you dig down. But we are all going to be on the same page along with the ODH and trying to help make sure that the language on the papers that you receive in the office and the way we're responding to these tests are consistent. So in the end, what do you do with abnormal results? Follow the guidance on the paperwork. We are working to update those with our ODH friends to make sure that they're accurate and give enough information. And then we will also be available for help as well. So we talked about a lot, actually, and I have this inclination sometimes to be like, oh, yeah, like I live it and breathe it every day. It seems so easy, but the more you dig in, even as somebody who's trying to put this talk together, the more nuances there are, the more, the harder it actually can be to understand. So we hope we've done an okay job giving you guys these take-home points. Is that earlier diagnosis improves outcomes. This is no longer a death sentence for babies. And when you're counseling patients on this might be CF, it doesn't have to come with all the gloom and doom that it did 10 years ago. The newborn screen is just a screening test. I hope you have a dream tonight about an abnormal screen and think about that sweat test that it's just drilled in to your heads. And then who needs a referral for more testing? You follow those instructions on the paper. And when in doubt, if you even think it could be CF, get the sweat test. And then here we have all of our contact information for every CF center. This is also information that comes with an abnormal abnormal newborn screen. But we added emails for all of the main contacts for each center. So if you have questions specific to your region or anything you'd like to follow up on from this webinar, please reach out. We would much rather take questions than to have more missed babies. So with that, we will take questions from certainly anyone who is listening here today. I also am supposed to show this slide. And Mark, you're welcome to pop on if you want to chat more too, but our final webinar, April 17th. Go ahead.
Speak to that. Thanks, Caitlin. That was thanks, guys. That was a wonderful, wonderful presentation. Just so practical and really good take-home stuff and a lot of very interesting material. So thank you very much. We're going to have another one that we in Ohio, we're just on the cutting edge. One of the other areas that we're on the cutting edge on, Nationwide and Cincinnati Children's are both participating in a project called Discover Diabetes, which is trying to identify children who are at risk for developing type 2 diabetes. That's a really interesting topic. And like I say, it's an NIH-funded study, and Ohio is figuring to be very central in this effort. So it's going to be another sort of cutting edge topic like today's was on things that are happening here in Ohio. So another webinar that will be much like this one, really across the state, and how Ohio is kind of leading the way on this one. So that was really a great topic, guys. I loved it. So do people have questions? We'd love to hear any questions you might have.
And feel free to unmute yourself and ask your question or enter it in the chat box. We can ask your question for you. And I'll just say quickly, this slideshow will be on our website following today's presentation. So any of that contact information will be on our website.
I thought your cases were particularly powerful. And if you really have a feeling something's going on, do not just assume anything. Good lessons. Great.
Well, we definitely enjoyed putting this together. So thank you guys and the Ohio AAP for helping us kind of gather our thoughts and put it in a format that can hopefully be used and help people down the road as well.
Yeah. If there aren't any questions, that'll conclude today. I want to also thank our speakers today. Again, that was a great presentation. I will send out information about applying for your CME credit for today's presentation. And then again, like I said, I'll send out the slideshow and any other notes that go along with this presentation in an email, either at the end of today or tomorrow. But thank you everybody for attending, and thank you to our speakers.
Thank you. Stay warm. Stay warm.
Thank you, everybody.